This is Louis Blevins of Pituitary World News, reporting from San Francisco, California. We're at Union Square. Today I have the distinct pleasure to interview Dr. Nelson Watts regarding bone disease and osteoporosis in pituitary patients. Dr. Watts serves as the director of the Mercy Health Osteoporosis and Bone Health Services Center in Cincinnati, Ohio. Nelson, thanks for joining us today to talk about pituitary disease and osteoporosis. It's been about a quarter of a century now since your first publication, which was really seminal on the use of bisphosphonates in patients with osteoporosis. A lot has happened since then. I wonder if you would care to bring us up to date.
It's been a very interesting time. We've gone from testing drugs that we thought might work, found that they did, and then gone back to figure out how they did what they did, to taking molecular pathways that have recently been discovered and developing medications that seem to be even more effective. And the interesting thing is we know how they work before we test them. Most people think of bone as inert, as much life in it as this chair. But they're bone cells that are constantly breaking down old bone and other cells that are constantly rebuilding. So every 7 to 10 years you have a brand new skeleton, even though from the appearance that it might have, it looks the same. The material is completely turned over.
So we often hear the terms osteopenia and osteoporosis. Can you tell us what those mean?
It's, I think, unfortunate that we've got those terms. In the days before we had bone density testing, we knew people had osteoporosis because they had fractures. So it's awfully nice to get some sense before a bad event occurs that something's on the way. Allows us to try to do something to reduce the chances of bad things happening. And bone density testing has helped us with that, to identify people at high risk of fracture before they have a broken bone. It's been about 20 years ago now. A group got together and used the output of bone density testing, which is the T-score, to define osteoporosis. And the purpose was to help epidemiologists, people who do population research, have some standards to be able to determine how many people in Spain have osteoporosis compared with how many in Switzerland or Sweden. And they said minus 2.5 or below on the T-score is osteoporosis, minus 1 or above is normal, and in between they said is low bone mass, which if you're just putting a label on a group of people is not a problem. But when you translate that into an individual patient, it sounds like a disease, but it's not.
So can you tell us how to measure bone mineral density and why is it important? So what are the problems having osteoporosis in the first place?
Well, we'd like to get some sense about risk for bad things before they happen. And that's the same principle that's used to measure blood pressure, to get a sense of who's at risk for having strokes or kidney failure, to measure cholesterol, who's at risk for having heart attacks. These are silent markers that are risk factors, and bone density is the most powerful risk factor for predicting future fracture, except for patients who've already had a fracture, where that fracture really is a sentinel event. If you take experimental animals and you measure how much density there is in the bone, then you break the bone, see how much force it takes, there's almost a straight line relationship. The stronger, the more dense the bone, the stronger it is, the more resistant it is to damage. And so in people, particularly with age, but a variety of hormonal disorders, bone mass may not accrue. So when you're in your 20s and you've reached your peak, you may not be where you want to be. Or more often you reach a reasonable peak level, but something happens that you lose bone faster than you normally would. You reach a point when bone density gets low enough that just even day-to-day activities can produce a fracture. It would be nice to know that you're heading there to do something about it before that fracture occurs.
So as I recall, most of us reach our peak bone mineral density in our 20s. It's stable until about age 35, and then it starts to decline. And what you're saying then is that certain processes might actually speed up that decline or start that decline sooner, and then you can end up with osteoporosis at an earlier age.
Right, so either you don't have much to start with, or you have it but you lose it.
And you mentioned hormonal causes, so what are the more common causes of loss of bone mineral density in patients?
Well, not uncommonly, patients or people will ask my background, and I tell them I'm an endocrinologist, and they don't know quite what that is, so I tell them that's glands and hormones. And then they say, what does that have to do with bones? But if you call the role of the endocrine glands, almost everyone has some role in skeletal health, either directly regulating calcium, like parathyroid hormone, or regulating metabolism, like insulin, or having to do with the rate of bone breakdown or bone buildup, thyroid hormone, cortisol, testosterone in men, estrogen in women. All hormones play an important role in bone. I do have some days where all my patients are men. I do have some days where all my patients are younger, in their 20s or 30s, but the vast majority of people who suffer from osteoporosis are older women, in part because they start with a lower bone density at their peak, and in large part because they have a significant loss of bone when they lose estrogen at menopause. So hormones are very important in bone health.
How important are calcium and vitamin D?
Well, I view calcium and vitamin D as the raw material for bone, and vitamin D is essential for the absorption and assimilation of calcium. I think there's been some recent interest in the lay press about possibly too much calcium causing increased risk of heart attacks or kidney stones. I'm not certain that that's true, but calcium and vitamin D are both called threshold nutrients, which means once you get enough, there's no benefit in getting more. So they're sort of like the Goldilocks fairy tale. Too little is not going to be good for bone health. Too much is not going to be good for bone health. Fortunately, there's a range of just right. Calcium 1,000 to 1,200 milligrams a day. Vitamin D, we can actually measure a blood test if we're concerned about bone health and see where the vitamin D level is and get over-the-counter supplements to move the vitamin D level where we want it to be if needed.
So in regards to patients with pituitary disorders, there are a number of different causes of osteoporosis. I think the ones that we see most often are those patients who have a low bone mineral density associated with growth hormone deficiency, or maybe Cushing syndrome and excess production of steroids, or maybe they've taken too many steroids. But I think some of the data now are clearly showing that what we used to consider replacement doses of steroids can be too much. And patients certainly who take too much thyroid hormone can end up having a low bone mineral density as well. So with pituitary disorders affecting a lot of these different hormonal systems that you mentioned previously, it's obviously a concern for the pituitary patient as to what might be their bone mineral density. And I wonder if you could comment in general on some of your experiences in these patients, because I know you've taken care of a lot of pituitary patients in your career as well.
So the pituitary patients can be a particular challenge. As you know, in patients who have thyroid disease with a normal pituitary, there are simple tests that will let us titrate precisely the right dose of thyroid hormone. Thyroid replacement, adrenal replacement, overdoing it in either of those can lead to bone loss. And failing to give testosterone or for women at the right age to give estrogen also can put bones at a disadvantage. There's a lot we need to learn about growth hormone excess or growth hormone deficiency and skeletal health. A lot more research needs to be done there. I think stepping away from the pituitary question and back to bone density, the current recommendations are to measure bone density in people who are at risk for problems, and age is one of those things that puts people at risk. So every woman should have a bone density test by age 65, every man by age 70. Younger postmenopausal women with risk factors, younger men with risk factors should be tested. And I think bone density testing would be an appropriate thing to consider in almost anybody who has pituitary disease or any of the hormone abnormalities or uses the medications that can put the skeleton at risk. The purpose of that, it would be a little bit different than the use for osteoporosis. It's simply a matter of assessing where are you to know where you should go. As an aside, I have a small number of patients who come through my door marked osteoporosis that I found they had Cushing's disease, and osteoporosis was the most prominent manifestation of that, and some pretty dramatic changes in people who didn't look like the textbook cases in the first place, but after successful surgery, lost weight, blood pressure improved, and certainly bone density got better.
That's fascinating. I've seen the same as well. And it's very interesting. I've also seen a couple of patients who had growth hormone deficiency that was the supposed cause of their osteoporosis. If you look at the growth hormone literature, most patients with acromegaly, rather with growth hormone deficiency, will have a lower bone mineral density than subjects who do not have growth hormone deficiency. And interestingly, studies are showing as much as a 10 to 15% gain in bone density within 5 years of starting growth hormone. Are you aware of those studies, and what is your thought about some of those observations?
Yes, I've seen those. First of all, it's a little tricky. Bone density is a ratio of mineral content to bone size. And so if you assume, as most of us do in adults, that the size of the bone isn't changing, then any increase or decrease in bone density must be related to changes in mineral. But if the size of the bone changes, and certainly that happens in teenagers as their bones are growing, the bone gets bigger at a faster rate than it incorporates mineral. Bone density might actually go down, even though the bone is getting stronger. So that was one of the issues with some of the early growth hormone work. You have to persist. Early changes look like they go in the wrong direction. Longer-term therapy appears to be heading the right direction.
Is there one thing you want to tell patients who have pituitary disease and might have osteoporosis?
Don't take your bones for granted. We have really simple, painless, inexpensive tests to find out the status of bone health. We have safe, effective, and in some cases inexpensive medications to make bones stronger and cut fracture risk by up to 50 to 70%. But if you or your doctor's not thinking about it, you won't be able to take advantages of the advances that we've seen in the last 25 years.
Dr. Watts, thank you so much for your time. It's been a tremendous discussion, very informative as usual, and wish you well.
Well, I'm grateful for your having me. I've enjoyed our visit, and I hope this information's helpful for your audience.
From San Francisco, I'm Louis Blevins, and that's it for this edition of Pituitary World News.
Twice. It's 10 million. It's underground.